One of the challenges to providing robotic-assisted minimally invasive surgery to all appropriate patients has been providers' limited access to their preferred technology. Just as laparoscopic surgeons before them, robotic surgeons have and continue to face barriers to accessing this technology. Patients and caregivers can benefit from having expanded or even unfettered access to Da Vinci when needed. The barriers to doing so are often cultural and structural, but thankfully manageable. I'm Molly Gamble, Vice President Editorial for Becker's Healthcare. I am delighted today to meet with three experts who have successfully navigated these aforementioned challenges while providing robotic MIS to the patients they deemed appropriate. Panelists, welcome. I am so looking forward to hearing your thoughts on this important topic. Before we begin, let's check in and learn a bit more about you, your role, and your organization. Dr. Pakula, I will begin with you.
Yes, thank you so much. I'm so excited to be a part of this panel today and an important topic that I have a lot of passion about. I'm Dr. Andrea Pakula. I am a general surgeon as well as a trauma acute care trained surgeon, and I'm the medical director of robotic surgery at Adventist Health Simi Valley Hospital in Southern California.
Thank you so much for being here, Dr. Pakula. Dr. Wang?
Yeah, thank you for having me, Molly. I too am excited to be here. I'm Eileen Wong, a general surgeon out of Swedish Medical Center, the Issaquah branch. Currently serving as a chief of surgery for our campus, and then also robotic steering committee chair for our campus as well.
Thank you so much for joining us, Dr. Wong. And finally, Dr. Beffa.
Hi, Dr. Dave Buffa. Really excited to be here with you today to talk about robotics. I'm a general surgeon in downtown Sacramento, Sutter Medical Center, Sacramento. We were doing emergency general surgery robotics for 4 years.
Terrific. Thanks, Dr. Beffa. Well, I thought we would begin our discussion today by establishing a baseline, and that is this: how do you define expanded access? Dr. Wong, let's start with you.
Yeah, for us, expanded access was real mentality of treating the technology as just a tool. And so for us, that was making our campus have access to it 24/7. And it was just thinking of the robot as a scalpel. And so our goal was to try and do that. And we were successful in doing that about 2 years ago.
Terrific. Dr. Pakula, let's turn to you next. Dr. Wong mentioned it was a mentality. How did you define expanded access at your organization?
Yeah, I'd actually have to agree. As a trauma acute care surgeon by my original training and fellowship training, my goals with respect to applying robotics was the same. It's just an evolution of minimally invasive technology. And I wanted to be able to offer all of my patients, regardless of time of day, the ability to offer them a minimally invasive approach. And using the robot just enables us to do some more of the complex procedures that we see, especially as patients become more complex, whether it's on weekends, at night, regardless of time of day. So for me, that's expanded access.
Mm-hmm. Terrific. And Dr. Beffa, is your definition synonymous? Is it different anyway from your co-panelists?
Pretty similar. I think basically, like they said, this is a great tool in the acute care surgeons, armamentarium, and just being able to do the case how the surgeon wants to do it whenever they want to utilize robotics, whether it be 2 a.m. or on a Sunday, then that's expanded access. If the surgeon wants to do it robotically at 2 a.m. on Sunday, and it happens, I think, congratulations, you've achieved, true 24/7 access. That's how it was for us anyway.
Well, conversely, now we understand how you define and look at expanded access. I would love to understand how you or your peers have seen access to Da Vinci technology limited. Dr. Pakula, can I turn to you first for thoughts on this one?
Yeah, about how I was limited or how we could be limited.
Yes.
A lot of it in the beginning came down to staffing, and it's always about staffing issues and the staff not being trained on the robot and things like that. But, and also, the robot was really just a 7 a.m. to 3 p.m. tool that we could use. But again, as everybody got educated, we were able to get everybody trained so that we can essentially apply the use of the robot at any time of day. But I think staffing is always the bigger issue, and it just comes down to education.
Dr. Wang, she mentioned staffing. Anything you would add to that in terms of constrictions and limitations?
Yeah, I think in addition to staffing, which I think everyone feels nationally, is obviously also culture. You could have the staff, but if they don't have belief in treating it, and that, again, going back to that mentality that it truly is a tool, it's a way to provide minimally invasive surgery to our patients independent of time. And I think that becomes a big hurdle for a lot of institutions. And so trying to change that mold was probably second on the list of our limitations as well.
So Dr. Beffa, we've heard so far staffing nationally, health institutions are seeing this, also culture. Anything you would add?
I think for us, I mean, it was some of the barriers early on for us were basically the ability to have techs function as the robotic first assist, and whether that was okay at our institution by the bylaws and through Sutter, through our hospital legal department. And so we really had to, basically make the case to our legal department at the hospital that yes, in fact, surgical techs can function as the robotic first assist. And once we kind of overcame that barrier and we got that through and approved, we really, that opened up a lot of just after hours operations for us on our team. I know a lot of people have struggled with just who is the right first assistant and when, what time of day and who's available. So that was a big breakthrough for us.
Well, each of you so far has alluded to the story your organization has to tell about expanded access. I'm curious to dive a little bit deeper into what brought expanded access on. When your institution's expanded access to where it is today, what were the centennial events that really brought on that change? And as you look backward now, how did you come to answer the question, why now? Dr. Buffa, let me stay with you for this thought for one more moment and hear your thoughts.
So for us, I mean, we started our robotic acute care surgery journey about 4 years ago. And early on, we were seeing some pretty amazing outcomes, especially, and so like on a Sunday, when we first started on the robotic journey, we were, basically, okay, you can utilize a robot Monday through Friday, typical hours, the regular block time. And the problem with acute care surgery is some of the sickest patients in the building are coming in at 24/7 after hours. So we were seeing great outcomes in the limited time that we initially had with it. And then at Sunday, at midnight, we got tired of seeing these patients where we were offering them one standard of care Sunday after hours, which was like a big open incision, versus if you could just hold on until Monday at 10 a.m., we can do this robotically with 5 small incisions and get you home in half the amount of time with less pain. So that kind of two-tier dilemma that we really stared in the face was honestly an ethical issue for us. So we really were driven to expand the after hours access because we knew that patient outcomes were better. We wanted to be able to offer that same standard of care, minimally invasive technology to people, regardless of the time of day. So we really started, that was kind of our driving force and wake up call that, hey, we gotta overcome whatever barriers are out there and just get this done for the patients.
So interesting. So you wanted to remove the connection between the timing of one's injury or health event to their outcome and expand access for those reasons ethically, which makes a lot of sense. Dr. Wang, let me check in with you here and see if that was similar to the events that transpired in your organization or any other commentary or events that dictated this decision to expand access.
Yeah, absolutely. I think everyone sort of sees the benefit of this technology in normal working hours. And so it seems like such a loss to not be able to provide that 24/7. I also serve as the director of our hernia specialty center. And for us, we had such a significant change in our data for length of stay when you're treating these complex hernias on this platform. Patients with large hernias were going home same day that weren't happening before. And so these patients come in, incarcerated. And why would you do an operation that you would normally do during business hours, minimally invasively, and then do it open after hours? And that was sort of for us, my group in particular, a big push for us to kind of gain that access as well.
And Dr. Pakula, let's hear from you too about how this decision was made within the walls of your organization.
Yeah, I mean, I was lucky in a way because I had been at 2 other previous institutions where I tried to incorporate acute care 24/7 access. And it took several months, but we were able to do it. But where I currently am, when I was brought into Adventist Health Simi Valley, they didn't have a robot. And so they wanted to build a program. And so really one of my main goals in doing so, I told them, I said, I'm an acute care surgeon, and I just kind of laid out the data and I showed them, and I said, we need to start the program from the beginning with everybody being trained so that we have the ability to offer equal care to every patient, regardless of when they came in. Just like Dr. Beffa said, these are the more complex patients. They have the physiology is they're sicker. And those are the ones that often come in at 3 a.m. And so there wasn't a reason not to be able to offer the same level of care. And we were seeing prior to the robotic program being started, so much of those same kinds of cases that we can offer robotically being done open. So length of stay was longer, post-op, whether it was morbidity or complications or what have you, may have been higher due to the rates of open surgery. So we really, I kind of molded that culture from the beginning. That was my goal. And luckily that's what we were able to do.
Well, it's also a very big endeavor to change culture, to change structures. So let's talk about that a bit. What were the steps you took? Who were the necessary stakeholders to really include in this process? And what may have been the resources that you really needed to leverage to drive this change? Dr. Pakula, let me stay with you on this thought.
Yeah, I think, it's all about getting buy-in from your executive team as well as the OR and the nursing staff. So I think some of the key stakeholders definitely were the OR director, the robotics coordinator, getting them involved so that we can start with education. My main goal, as I said, was to get everybody trained with regards to staff, nursing and techs, so that there wasn't really the excuse that we didn't have the trained staff for the weekends or after hours. And then, of course, administration. So whether it was the CEO, COO, CFO, business development, all of those executives were on board and involved so that we could show the benefits with respect to outcomes and data. And the resources, really, I got to say, Intuitive was instrumental in supplying some of those resources, whether it was the Genesis team coming in to help with efficiencies, whether it was the Market team with respect to helping to gather data and really show that. But everybody together was what was needed and how we were able to achieve the expanded access.
Dr. Wang, you mentioned education was very key, executive buy-in, executive champions. Any other resources or steps that were absolutely critical as you took on this effort in your organization?
Yes, absolutely. I mean, I can't echo enough the importance of that message coming from the powers that be and how effective that is with the staff. And so we had, essentially sort of a meeting in the morning that said our CNO, our OR director, and our medical director and myself sat in a room with all of the staff that are standard in service. And we said, we are moving towards robotic access 24/7. And then it sort of was this, okay, this is happening. And, aside from the data, to get the buy-in from our executives, and again, I can't say it enough, the powers that be, I think for the culture, which you can get buy-in and have people say that this is the direction we're moving towards, but unless you change the culture of the people, the quote unquote boots on the ground, that transition can be fairly painful. And what we found, I think, at our hospital that was very significant was we underestimated how much our staff actually cared. And we ended up bringing in patient testimonials for cases that we had started to do after hours. And that was probably the biggest change agent that we could have had in our staff. And to a point where now individuals are, why aren't we doing this robotically? So why did this person not qualify? And it's an engagement that we had never seen before. So I thought that was a big critical move for us to kind of have a successful program.
Let me just follow up with something you had shared, because I think implicit in your remarks is the idea that change like this is not really achievable without executive support. And I don't want to assume, but is that correct? Can you achieve change like this without your executives buying in and backing you?
I personally don't think so. And you wouldn't want to necessarily go down that road without your executive support. And I think it needs to be a collaboration, because I think believing in the technology after hours is sort of believing in the technology, period. So sort of a global perception of what this provides to the patients.
And Dr. Pakula, let me turn to you here, because I'm curious what you would define as the most critical of your examples that you had shared in terms of gaining support from administration. If someone is just trying to begin to round up that support and trying to begin that effort, where should they start?
Yeah, I think that, it comes down to, again, my two main things I think are education and data. And so when we were even in the early discussions about starting a program, I had all of the executive suite and the executive team in for, as well as the OR director, in for, and I gave talks. I just gave talks about what robotics is, what the benefits are, showing outcomes, showing the actual data. And then as we did that, and as they saw that, and then once we started doing even the cases that weren't after hours, even the PACU nurses were saying, it's incredible, the difference that these patients, how well they do after surgery and how quickly we can get them out of the recovery room with minimal narcotics compared to what we were seeing before, let's say. And so I think just educating everybody, really being open and partnering with your powers that be, as Dr. Hwang said, executive team. And then to help with all of that, of course, because I think you can't just be one surgeon trying to do it. If you really want to build a program, everybody needs to be involved and hopefully share a similar vision. And I think that's how you can get there, in my opinion.
Well, Dr. Buffa, we heard from your co-panelists about how they started these conversations with their powers that be, as was so eloquently put, and others on their teams. But you have to have an idea, too, of what you're going to expand, when, and who's going to be involved. For the surgical leaders and operational leaders in the audience today, how did you know which procedure, staff, and timing would be best suited for expanded access hours?
So for us, I think I totally agree with you don't want to be just a one voice advocate at your site for robotics. You want to ideally have a robotic steering committee. If you don't have one, form one, like Dr. Pakula was saying, and then ideally make that as multidisciplinary as possible, meaning, get your gyn-onc on there, your urologist, your OB/GYN on there, so that you've got a unified voice that is very powerful, rather than just one surgeon going to, the C-suite on their own. You've got, 3 or 4 different disciplines within the OR coming to them with unified voice saying, we need this and this is why. But in terms of your question about just the which staff, when, and which procedures, I think keep it as simple as possible is key, especially in the beginning. I mean, our journey, we ended up basically starting with cholecystectomies, robotic cholecystectomies on the emergency general surgery team, something that everybody on the team was super comfortable with, and just using that basic operation to get the techs and the OR staff comfortable with the robot, comfortable with the instrument exchanges, something that everyone was comfortable with. And we used that as the foundation, then built out from there. And, we basically had outcomes data from 3 years of robotic choles where we were faster, cheaper, and had better patient outcomes with less conversion to open and less need for subtotal cholecystectomies. And we kind of had a win with something that was straightforward. People got comfortable with it, then expanded out into, colectomies and incarcerated hernias, small bowel resections. The who we also identified at our site. We identified 2 case complexity tiers, with surgical techs being allowed to be the first assist on tier 1 or straightforward cases, cholecystectomies, APIs, inguinal hernias, ventral hernias, and then for more complex tier 2 cases, we had PAs, NP, or second MD required. So I think you can kind of build it out in a stepwise fashion. Everybody wants to just dive right into robotics and do super complex cases. But I think if you do it in a stepwise fashion, start simple and get your team comfortable, then go out from there, you'll have better luck and more success at expanding into after hours. Because you don't want to just do a super complex, you don't want somebody on your team trying to do a super complex case at 1 a.m. They may, create a lot of barriers inadvertently if it's a really long case. It might not be the best way to go. So I say start simple, go complex from there.
Dr. Pakula, Dr. Beffa's advice, keep it as simple as possible, at least in the beginning. A 2-tier system for complexity was put in place. Any other advice or guidance you would offer when it comes to the who, the when, and the why, or the what?
Yeah, I think I completely agree. I think even when surgeons are training, I think it's no different from expanding your access in your hospitals. To start simple, start with exactly what Dr. Beffa said, is start with the procedures that we know. Start with the procedures that the techs know and the nurses know. So like he said, gallbladders are typically the most common. They're very comfortable. At least they know that procedure. And so learning the instrumentation as we're expanding into after hours is much simpler. And then, you can start to push it a little bit with respect to the complexity of the cases. I personally, we only have techs. We don't have any PAs or NPs. So we don't need to utilize PAs or NPs or first assist unless the surgeon wants one. Then of course, like one of my partners, if he has a difficult case, he'll call me in to assist, and we have no problem doing that. But I think the purpose is just to get everybody comfortable with the technology. The time of day shouldn't really matter, right? The goal is just that it doesn't matter the time of day. We're doing the cases that we would do in the morning. But I think that's key, is to start simple and then just grow from there.
Well, Dr. Pakula, let me stay with you for a moment, because I had said in my earlier remarks that structural and cultural change is not easy. It's quite difficult, but we haven't really gotten into why or how. What were the most significant barriers to change that you faced in these endeavors and in this effort?
Yeah, I think probably you couldn't have said it better. Culture in an institution is very, it's just there, and it can be very difficult to make those changes. I think the main barriers, part of it was from anesthesia. Again, where I am at Adventist, they had never even seen a robot. They really didn't know what robotic surgery was. So they had heard about it. Maybe other hospitals had thought they had other programs where cases may have gone slower. So anesthesia had some issues initially. Again, nursing, even in the pre-op and the recovery room nurses, there were just questions. And I think trying to change that culture was just to get everybody excited about it. And the way that I do that is I love to talk about robotic surgery, and I love to teach about it. So it came down to just educating as many people as I could. And I said, look, come into the room, see what the case is about. I want you to be there for first cases. We'll see how quick or not quick that they are. And then you can, make a judgment, if you will. And just doing that over and over again and reiterating the importance and the outcomes. I mean, patient testimonials that's a great idea that Dr. Hwang did. I think that shows it as well when these patients are coming out of surgery and they're going home much faster than they would have with potentially a different approach. So I think those are some of the barriers, were just the misconceptions about robotic surgery and how long the cases may take. And it just takes time and education and proving it, in person, letting them see it. And that's what helped to make that change.
Perfect. So doing a bit of myth busting, if you will, familiarizing your colleagues with the technology, normalizing it. Dr. Wang, anything you would add in terms of barriers you encountered and how you got over them?
Yeah, I think I was really fortunate to have an executive team that had belief pretty early on. And so a lot of and I hate to call it resistance, because I don't think they were intentionally trying. It was more of fear of not performing well, or fear of their inability to manage the robot or provide the right instruments on the weekend would slow the case down. And so it really was sort of building the confidence in the staff. And so just like Dr. Pakula said, and even Dr. Beffa had relayed to, is we do very frequent in-services as surgeons. Anytime we're going to introduce a new type of surgery, we will do a 30-minute in-service with the staff. Mm. And, I think what's interesting is they'll record it. So then even our night teams can see that as well. And, some of our circulators, their first cases that they're doing are after hours on the robot. And I think that that's a big step of saying, yep, at some point you're going to get exposed to this, and not thinking of the time as being a relevant factor as to when you are exposed to it. So it really is giving them the opportunity to have confidence in their ability, and then also giving them the opportunity to say, I am not comfortable with this, recognizing the safety of culture, and saying, these are our options, and truly saying, okay, if you have a staff that's not comfortable, then you have to, as a surgeon, also say, okay, what are our options now? And I think giving them that voice and giving them that confidence is really, really important.
Most definitely. Let's shift gears a little bit to talk about what you've seen in terms of outcomes and results of expanded access. Your 3 programs have implemented expanded access initiatives. Now I'm curious, does the data support the work? Are you seeing the results and the changes that you had hoped for? Dr. Beffa, let me turn to you first for your thoughts on this.
Sure. So, we've seen amazing outcomes on multiple different surgeries, but our biggest experience, just being 100% emergency general surgery service, is the cholecystectomies. We've done. We basically have 3 years worth of outcome data on emergent cholecystectomies, and averaging out over the 3 years, we've been less expensive robotically, we've been faster robotically, and we've had markedly improved patient outcomes with less conversions to open, less post-op bio leaks, less complications overall, and shorter length of stay. So it's been truly a win with kind of the workhorse of emergent general surgery, which is cholecystectomies. We've cut our colectomy length of stay in more than half, from going from open colectomies 5-6 days sometimes for us in the emergency general surgery service down to 46 hours post-op. And so we continue to try to just push the envelope with, as a creative tool in the emergency general surgery skill set, like what can we use this for? And so we're trying to just look at these outcomes and just expand into different ways we can use this tool that your hospital's already purchased. We're just trying to use it after hours. So we're trying to do outcomes research on as we build a bigger case series in each of the kind of emergent general surgery cases.
Dr. Wang, let me turn to you and see if there's anything you would add from your experience. And also, I'd be curious to hear your thoughts about whether these changes have affected patient or care team satisfaction.
Yes, I think that our data sort of reflects what our daytime data already shows, right? In that, particularly our complex hernias, those patients are now going home day one, with the exception of those that potentially need resection. And then for our staff and satisfaction, I think with the staff, they get this real sense of ownership that they're a part of something new and a part of something that really changes patient experience. And that is such a valuable, I don't know how you can calculate that or how you can put a number on that as far as how to continue to grow and build the program. But I think for that, it's when they hear the testimonials and when they see the patients or see the data that patients are going home the next day, it really gives them the sense of pride that they're a part of this. So yes, it's definitely been, the data has really changed attitude.
I imagine it's a pretty powerful initiative to be a part of. Dr. Pakula, let's turn to you to see if there's anything you would add here about outcomes, data, and then also satisfaction and patient-physician care team experience.
Yeah, I mean, I echo what they both said. With respect to the outcomes data, we track everything as well, and we've definitely seen improvements with respect to length of stays and all of the after-hours acute care cases. Getting the other surgeons excited about it and training. There's a few surgeons that have been able to get trained here so that they could start doing much of their acute care surgery as well robotically. But with respect to the care teams, it's interesting because I just got asked by one of the charge nurses, they do their monthly nursing meetings. And she said, the nurses are really excited to hear more about what this robotics is, what it is that you're doing, because obviously they don't see it. They just see the patients afterwards. And so I'm going through and meeting with the physical therapists, the dietitians, every aspect of the care team. And they've been able to see the changes with the patients on the floor. And that's been extremely valuable. I mean, yeah, like she said, you can't quantify that they're so excited to see how well the patients do that they're wanting and talking about robotics now. It's kind of a buzz, across the hospital since the program started a year ago. So it's been extremely beneficial, I think.
Well, before we finish up, I wanted to check in and learn from you some watch outs or some considerations that you would like to share with attendees with us today. I think the past couple of years have shown us even the best plans sometimes can run into surprises or challenges. Did your transition from limited to unfettered access go exactly as planned? And if not, what are some watch outs, like I said, that you would encourage your colleagues to keep an eye out for? Dr. Pakula, can I stay with you for this thought?
Sure. Yeah, I think, like I said, I've been in a couple of different programs, and I've definitely learned, as I've grown over the last 5-6 years that I've been doing robotics. I think the main thing is we get very excited about it as a surgeon, but you can't just push it on people, right? You can't just say, hey, look, this is what I do. I'm acute care surgery, and I'm going to do all of my cases on the robot, like it or not. You really have to be thoughtful about getting the people trained, getting the buy-in from everybody, because I think, like we've all said and agree, you can't just be one person and then think that you're going to, be able to drive change. It really needs to be a group effort, a partnership with everybody. So I think for me, no, it's not always easy, because I was very excited early on and I wanted to change it. And then from that experience, I learned as we got here, in order to build a successful program, 24/7 access and allow all patients to have an MIS robotic approach, is everybody's got to be involved and trained and comfortable before we move forward. So it's probably the biggest takeaway for me.
Make it a collaborative effort. Dr. Wang, anything you would add to this in terms of watch outs?
Oh yeah, absolutely. I think, I love doing these because I always somehow learn something from the other people on the panel. And so when I hear them initially talk about how they, I would say, kind of took a stepwise approach to opening the gates to the robot, in hindsight, that probably would have been a nice thing to do to my staff, as opposed to just making everything available. And the second point, or the point after that being, you get one bad case, one case that takes too long, one case where they ended up converting to open, or, not necessarily a bad outcome, but just sort of a change in direction in the mood of the room. And that case sort of taints the idea that robotics should be 24/7. And understanding that any program, any technology is going to have that. You have to be able to bounce back from that. And so whether you take a metered approach or whatnot, those cases will happen. And just kind of recognizing what's your tool, how are you going to bring the staff back from that? Does it require, a sort of a sit-down review? And just saying, independent of what type of case it was, eventually adding some form of technology to a program, those things will happen. So I'd put that in your back pocket as it being a likely chance of it occurring.
That's such a great point. Be ready for that one case, for that one outlier, and be ready to how you communicate with your colleagues about that. Terrific. Well, we now have a few questions that have come in from the audience that I want to ensure we get to in the time we have remaining. The first is about how you handled assisting robotic cases in the off hours. Did you have an on-call PA or FA? Dr. Beffa, can I turn to you for your thoughts first on this one?
We basically built in PAs to be on call with us, so we had the luxury of doing that. And I would say that's kind of the first choice, is to have some type of structured first assist call, so that you don't rely upon possible variability among robotic techs, whoever's on call, or surgical techs, whoever happens to be on call that day. But if you have to rely on surgical techs, then I think, developing like a training curriculum, like Dr. Hwang and Dr. Pakula were referring to earlier, we developed a training curriculum where, to be a tech who's robotically trained, they observed 3 cases, they did a dry lab with the intuitive rep, and they were ready to go to essentially, be on call with us. We've started moving towards having any tech who's on call with the surgery team to make it mandatory. We're floating around the idea of making it mandatory that they're robotically, have gone through this training curriculum, so that you have somebody, whether it be a PA, another MD, or a tech who's familiar and ready to go, so that, minimize the barriers. And that's kind of what we've done.
Any other differences to process that are worth noting, Dr. Pakula or Dr. Wang?
I'm in a very similar situation where we have 5, I'm going to say excellent because they are excellent, PAs that support us. And then they also support additional services on campus. There's always at some point there's turnover and you have a new PA. And so that waiting for them to become robotic trained. But having that consistency and knowing that that's available has been a huge benefit to us being able to do it somewhat seamlessly.
Perfect. Let's move on to Dr. Pakula, are you going to add something there? Go ahead.
No, I was just going to say that I'm literally the opposite because we don't have any general surgery PAs or NPs that work with us, let alone take call with us. So it is really, we rely heavily on the techs, and luckily, because they've all gone through the training, and we do exactly like what Dr. Beffa described, which is they come in and they scrub, but they don't really touch anything. They do dry lab and that's for a number of cases, and they do a dry lab with Intuitive, and then they get on the robot and they start, with an experienced tech. So we rely heavily on the techs, but it's been good to get them all trained so that they are all, pretty comfortable when it comes to doing these cases after hours.
Thank you for weighing in on that question from the attendee. Another attendee wrote in expressing some concern about staff proficiency if there is a case only scheduled once a week. They'd like to know, did you establish a minimum number of cases that had to be scheduled? Dr. Beffa, can I turn to you again for thoughts here?
I mean, I think that's always the challenge, as a acute care surgeon, it's, you never know what's going to come in. So therefore, how do you, get the number of repetitions so you're ready to go for the case? And for us, I think the way we accelerated the learning curve, at least for the surgeons, was when we were trapped in-house on call, we would go and literally shadow some of the high volume elective robotic surgeons and, take notes and cell phone videos and just, we were going with the colorectal surgeons and see how they're doing their colectomies so that we kind of had that experience and felt immersed in it after a handful of shadowing those cases. We paired that with some of the excellent Intuitive courses, which are very hands-on cadaver courses. And we kind of had our robotic plan in place for when, the right, colectomy patient came in, and again, we didn't just dive into the colon. We built a foundation with the gallbladder and then got more complex from there. So after we got our sea legs with the gallbladder on the robot, we then kind of were preparing for the first emergency general surgery colectomy. And we were prepared by that in-house shadowing plus courses in advance. And then we were ready when the right patient came in. So I think all those things come together and you have your plan in place, but you got to have your plan plus have done your homework so you can actually be ready for when that patient does come in after hours. It's not just a random event. You planned for that event.
And finally, the last question that we will address from attendees, was there any resistance from your after hours teams? Dr. Beffa, I hear a slight chuckle out of you on that one. Anything?
Yeah, of course. I mean, I think like anything, I mean, this is major cultural change, like both Dr. Hwang and Dr. Pakula have been saying. And so, I think, and I think, I don't know what their experience has been, but I think a lot of it is just the fear of the unknown in the text. Once you overcome that with like a formalized training curriculum, next thing you know, they're kind of excited about learning something new, just like we all are, And so I think you get overcome that fear of the unknown, and then you've got some techs, plus or minus build in a call requirement that if you want me on the surgical call, have the robotic surgery tech complete this training course, which keep it basic and simple, so it's not, a big ask. And I think you'll get over probably 75% of the barriers, the cultural barriers that stem from the fear of the unknown. And then the last thing I'll just add, have a realistic expectation for this major cultural shift, meaning there will be conversions to open, especially in the emergency general surgery space. And that's okay. That's good, especially in the beginning, because that's the right thing to do. And so, setting the stage and expectation at your hospital that this major cultural shift is not going to be perfect at the beginning. There's going to be a learning curve that everyone is on, and that's okay. And we'll go through this journey together is going to be key to success.
Some powerful closing words from Dr. Beffa. I want to open it up to your co-panelists, see if there's anything they want to add in closing.
Yeah. Well, what Dr. Beffa referred to with fear of the unknown, it brings me back to early on when we were starting the program there. We had techs that were available, but there was 2 different occasions when the nurse wasn't trained, so to speak, on the robot. And I said, you know what, that's okay. I will scrub out and I will drive the robot in with you. It's only going to take an extra couple of minutes just so that you could see that it's not that scary. It's not that big of a deal. And just doing that, I think they were so appreciative, and obviously they saw that it wasn't that difficult and didn't make that much of a difference, but they were so appreciative to say, okay, you're going to scrub out, show me how to do this. So just overcoming that fear is absolutely correct. And yeah, you can convert from robotic to laparoscopic to open. You're utilizing an instrument that what you feel is going to offer a better, potentially, sometimes even safer, because of the visualization approach to your patient. And so, whatever you need to do to offer the safe surgery for that patient, as long as everyone is aware of those possibilities, then I think, the institution, the hospital, the staffing, everyone's going to grow together. And I think ultimately become 24/7 access and expanded access and be able to offer that.
Dr. Wang, anything you would add in closing?
Yeah, it's always interesting when people say the same things that you experience. And it's nice to also know that it's reproducible to get over the hump. Fear is contagious, and it will find its way to anywhere in the hospital. I can remember even getting resistance from SPD saying, if you use all of the cameras overnight, I'm not going to have any cameras for the day surgeries. And battling that and trying to figure out how to handle that. My response to that is confidence is also contagious, and that knowing that we're capable of doing this and getting it done a couple of times. I think for us as surgeons, if you want this to succeed, you have to take an active role, not just from the person who's pushing this, but from all surgeons, being in the room when they're setting up, being available to answer questions when they're trying to set it, pull material for you. We make sure that we have all cell phones for all of our surgeons, not just robotics, to make sure that everyone's accessible. And you can't expect to have a program just show up. It has to be not just one person pushing it. It has to be a joint effort from everyone. And so if you get that, it's not just culture and staff, it's culture and surgeons as well. And I think I'm really lucky to have a bunch of surgeons at my hospital that really are collaborative. We cooperate with another, and we also cooperate often as well. And I think for the staff to see that, it was especially on these cases after hours as well, it really made them realize how important it was to us. So I encourage anyone who's trying to do it to take at it lightheartedly, but also sternly, and anticipate many bumps in the road, that they are very overcomable, if that's a word.
I think so. I want to thank each of you, Dr. Buffa, Dr. Pakula, Dr. Wang, for illustrating for us a lot of hard work on your behalf. It took, I imagine, a great amount of time, and condensing it into the past 40 minutes to really drill down to some key takeaways for our attendees. So thank you so much. Attendees, this has been Driving Cultural Change to Break Through Expanded Patient Access Constraints. Thank you so much for joining this session. You have about 10 minutes until the next general session begins. Thank you very much.